So we're going to get started, and I'm Charlie Murray. I'm with Class 3 Democrats. The Democrats are hosting this, but this is not a political event, so we're co-sponsoring it with Talk, and we appreciate everybody coming. There's water and cookies back here. The cookies are not store-bought, so they're very good, and we don't expect any of them to be here at the end of the meeting. So, but if you get thirsty, please get up and get something. We have 4 speakers. We really appreciate everybody coming out tonight. I think this is an interesting issue. It's in the news. It's in everybody's mind. If you're still working for a company, I'm not. So if you're still working for a company, hopefully the company is covering your health insurance now, but that may change in the future. So if this isn't directly affects you today, it's affecting one of your neighbors in Glastonbury. So again, I'll turn it over to Candace.
So I just want to say thank you to Charlie and the Democratic Town Committee, first of all, for hosting this. I think it's an issue that a lot of people, as Charlie said, it's on their mind all the time. A lot of people are really concerned about it. A lot of people are worried about losing their insurance, but even if that's not the case, this is going to impact all of us. So I'm really excited with the panel that we have, that they can give us some insight into what's going on right now in the current state of healthcare, and maybe answer some of the questions that we have and prompt a discussion about what we do from here, moving forward. So also I want to say thank you to Talk, which is a local activism group, Truth in Action and Loving Kindness, that I'm a part of, and they really helped organize and plan the event. So it was an effort between the Democratic Town Committee and them. So I just want to introduce our panel. We have Lynn Ide is going to be speaking first. She's the Director of Program and Policy for the Universal Healthcare Foundation for Connecticut. She's responsible for the development and coordination and the execution of the Foundation's healthcare policy advocacy, outreach, and education efforts. She's also one of the founders for Protect Our Care Connecticut, which is a campaign to preserve and strengthen the gains made by the Affordable Care Act and defend Medicaid, Medicare, and women's health programs. Previously, Lynn also had leadership positions for the Connecticut Housing Coalition, Legislative Electoral Action Program, and the Connecticut Citizen Action Group. Next speaking will be Andrew von Austrian. Sorry, Andrew, if I got that wrong.
Close enough. I've heard worse.
Andrew is a lead strategic planner for Cigna. Prior to his role there, he spent 16 years in health policy and lobbying roles, including time at Medtronic, which is a medical device, one of the largest medical device manufacturers in the world, for a DC-based healthcare business trade association, and for the advisory board company, which is a hospital management consulting firm. Dr. Joel Reich is here. He was the Chief Medical Officer and Vice President for Medical Affairs at Eastern Connecticut Health Network for 18 years. He was also a practicing emergency medicine physician in that network. In his time as CMO, he led the health system's clinical integration that began with the passage of the ACA. He's also involved at the national level as the chair of the governance work group for the Accountable Care Learning Collaborative. Okay, thank you. Which is focused on multiple aspects of healthcare reform. And finally, we have with us Ellen Graham. She is Senator Blumenthal's Community Liaison for Environment and Healthcare. So thank you all for being with us, and I'll let Lynn get started.
Thank you. Thank you for having me today. Good evening, everyone. I'm going to stand up because I'm short, and I'm also, if you take a test in communication styles, I'm a presenter, so I got to stand up. I appreciate you all asking me to come here today. As was said in the introductions, I work at the Universal Healthcare Foundation of Connecticut. We're an activist philanthropy whose mission is to be a catalyst for democratic, with a small d, change of our state's healthcare system with a goal of achieving quality, affordable healthcare for all state residents. We have sort of an activist beginning. Unlike many foundations, we're what you call a conversion foundation. There are 3 of us in the state, and they are formed when a for-profit entity takes over a not-for-profit entity. In our case, it was when Anthem bought Blue Cross Blue Shield. There was a court case where the consumers and other advocates like Dick Blumenthal and Nancy Wyman at the time took the case to court and said that all the assets of the not-for-profit should not go to the for-profit entity because they were accrued under a nonprofit tax status. And so a pot of money was set aside to start our foundation. So those are our roots. We joke in our office that working on health reform is like a life sentence without parole, because it is just ruthless, especially in the climate that we're in right now. And what I want to do is just give a little bit of an overview of what's happening in DC, how it relates to Connecticut, and some of the things that are happening in Connecticut. Because I'm finding when I've been talking to people all over the state since November 8th with a lot of the groups that have started around Connecticut. And people are very focused on what's happening in DC, not to take anything away from the magnitude of what is happening in DC. But we also need to acknowledge that our state has a responsibility to the people in Connecticut to do what it can to protect the health and welfare of the people in this state. And we are facing a governor and a legislature which are tending to just say, oh, they're doing that down in DC. We have our wonderful congressional delegation, all of whom support protecting these things. And we are not responsible here in Connecticut at the leadership level, and that is just wrong. So as you can imagine, I'm not very popular with some people. Even though I will say I am a Democrat, but Governor Malloy isn't exactly a fan of ours because we have been very critical over the years about our state's lack of leadership on healthcare reform. Although we have done some wonderful things, we could be doing so much more, like some of our neighboring states. So you've heard the big news today, about the Congressional Budget Office released their score of the federal, we call it at our office, not the American Health Care Act, we call it the Un-American Health Care Act. So rather than leave 24 million people uninsured by 2026, it will leave 23 million people uninsured by 2026. And it will basically decimate many, many programs that many people count on, such as Medicaid. Here in Connecticut, we call it Husky. Can anybody venture a guess as to how many people are on Medicaid in the town of Glastonbury? Just throw out a number.
3,000.
A little over 3,000 people. Does anybody know how many people in the state of Connecticut are on Medicaid?
500.
750,000 or so. It's about a quarter of the state's population. And so there's a lot of bad, negative stereotypes that are put on Medicaid, but it is basically the fallback for people who have the kinds of jobs that are not providing health care coverage through employment. Many working people, many independent contractors and other people whose income falls below a certain percentage qualify for Medicaid and Husky. Many people who are elderly, much of our state's Medicaid money goes to nursing homes to pay for long-term nursing care for elderly and disabled. Crippling our nation's Medicaid program has huge, absolutely massive budget implications for the state of Connecticut. And we think we're in a fiscal crisis right now with our state budget. If they decimate Medicaid funding that comes from the federal government, we're going to be in real trouble figuring out how to cover people. Hospitals, made out when Medicaid was expanded in our state. Governor Rell, when she was governor, became one of the first states in the country to take advantage of the Medicaid expansion under the Affordable Care Act. And we got single poor adults who we were paying for out of the state administered general assistance program with our state tax dollars onto Medicaid. And that really helped those people out. Hospitals have been helped out because it's decreased the number of uncompensated care patients that walk through the doors and things of that sort. So the Affordable Care Act, the Unaffordable Care Act will do a lot to decimate the system that we have going in our nation. I have a wonderful fact sheet here that gives you the state implications of the proposal that's on the table right now. We updated it earlier today, not knowing when we get the congressional budget score, but trust me to say that this is pretty good general information right now, and I'll pass it, I'll keep a couple for you guys. This will just give you a sense of what to expect. I want to talk about a few of the other repercussions. What's going on in the healthcare marketplace is a lot of uncertainty and fear, and in some cases, from a consumer perspective, one might view it as rather almost even predatory. But we have a highly consolidated health insurance marketplace. Sorry to my Cigna partner over here, but highly consolidated health insurance marketplace in Connecticut. There are only two insurers, Connecticut and Anthem, that are saying that they will sell insurance in our state healthcare exchange, Access Health CT, for 2018 policies. And not many more that are offering outside of the exchange in the individual and small group market. And those are the two markets that are really very vulnerable. People who have to buy insurance for themselves and their families because they're not getting it through an employer, and small businesses that are trying to provide coverage for their employees through employment. I was at the Access Health CT board meeting last week, and they extended the deadline for the two insurers, Connecticut and Anthem, to decide whether or not they're going to offer plans at all in 2018 to September 1st. Meanwhile, Anthem and Connecticut have put in their rate requests for 2018 policies. So everybody who has to buy in on Access Health CT or outside of Access Health CT in the individual small group market, they're asking for a range of about a range of 19 to 52% increases. Anthem is asking for, and Connecticut is asking for 8.4 to 18.7% increases. That's in the individual market. And so the insurance department in Connecticut has a rate review process, and they will review these rates. These rates are assuming that the insurers will be getting the cost-sharing reductions that are in the Affordable Care Act that help control out-of-pocket costs for people at 250% or below of the federal poverty level, so that they have less of a burden for copays and deductibles, out-of-pocket expenses, because that's a barrier to care for many people. If you're working paycheck to paycheck and you have to pay a $6,000 deductible, or you have high copays for prescription drugs or going to the doctor for non-preventative issues, you could really be in trouble. The insurers are saying that if the cost-sharing reductions go away for 2018, which the Trump administration is really diddling around with this, they aren't sure about how they're going to deal with the court case that's going on, where the Republicans in Congress went to court and basically said that we shouldn't be paying these cost sharing reductions to the states under the Affordable Care Act. The previous presidential administration, Obama administration, was defending it. Trump, his office can't decide how they want to deal with it, and they've asked for a 90-day extension, which essentially is going to throw the health insurance market and the individual and small group market into complete disarray. And so we could be faced come September 1st where there's only one insurer or no insurer offering health insurance to those individuals and small businesses. And so when I say Connecticut could be doing something, they absolutely could. You look around the country and you look at what other states are doing, and they are getting ahead of the curve. And they are saying, we're going to extend enrollment periods. Some are saying that they're going to consider enforcing the individual mandate to keep the healthier people in the marketplace. There are creative things that are happening in a number of states. To that end, Nancy Wyman, thank God for Nancy, who's sort of the healthcare czarina for the state. She has the healthcare cabinet and Access Health CT and a lot of these healthcare responsibilities, the state innovation model, all under her umbrella. She has just gone out on her own a couple of weeks ago when they passed the Un-American Affordable Health Care Act in Congress. She said, I'm going to create a bipartisan working group to come up with suggestions for what we can be doing at the state level to deal with this crisis that's coming down the road. And the people that serve on that are Nancy Wyman, Vicki Veltri, our former healthcare advocate, Jim Wadley, the head of Access Health CT. 2 Republicans have been submitted, are on it, put forth by their leadership, and 2 Democrats. The 2 Republicans are Senator Kevin Kelly and Representative Terry Wood, not from this part of the state. The 2 Democrats are Senator Larson, not Congressman Larson, Senator Larson from East Hartford, John Larson's brother, and Representative Sean Scanlon, who's from the Shoreline, who also happens to work for Chris Murphy. That group has yet to meet, but we are really targeting that group to try to put citizen pressure on them and get them to go around the state and hold hearings where real everyday people can show up and talk about what they'd like to see happen here in Connecticut. They may need to call a special session of the legislature if the markets all start to fall apart at the end of the summer. They may need to, have the legislature pass some things. They may need to put pressure on our health insurance exchange to do some things. So we will wait, and we're not going to wait. We're going to try to be active in that. The other thing that's happening is Medicaid is getting hit, with a double whammy, with a triple whammy. The state budget is in crisis, and they are suggesting cutting coverage for Medicaid people at the state budget. Then we have the cuts that are coming down in the Trump proposed budget, which won't end up being the Trump budget, but it will be some version of something that the Republican-controlled Congress supports, and then the decimation of the program through this American Health Care Act, potentially. So on Tuesday, there's a press conference at the Capitol, at the LOB at 11:30. If anybody wants to come stand in solidarity with people who are on Medicaid in this state, you're welcome to show up at the Legislative Office Building at 11:30 in room 1A. And then one last thing I want to say is that this Protect Our Care Connecticut campaign that has started already has about 30 organizations that have signed on. We are looking for organizations that want to sign on to the principles of preserving and protecting and being creative about how we can provide care for people, protect Medicare, because one thing they're talking about at the federal level is turning Medicare into a voucher program, basically privatizing it and giving seniors a voucher to go buy insurance in the private marketplace. So we really need this campaign at the state level to stick together across constituencies. Women's health programs are proposing, they're proposing cutting funding to Planned Parenthood. And contrary to what some people believe, that's like the first place that a lot of young women get comprehensive health care oversight, not just birth control, not just abortions, but real care. So our campaign is working to fight against that. I have a sign-up sheet, or you can go to our website, protectourcarect.org, and sign up there. But if you're interested in getting on the distribution list and knowing what the Protect Our Care campaign is doing in Connecticut, you can get, we don't inundate you, there will be action alerts and things that you can do to get involved. And then I'm going to stop there. Our next Protect Our Care meeting is June 19th at 1 in the afternoon at our office in Meriden, if anybody wants to join us. I know Judith has been coming to the meetings. And we're planning on doing an action summit for healthcare activists on Saturday, September 16th at Middlesex Community College. And I will stop there. I can pass this around if anybody wants to sign up.
Candace, you want me to hop in?
Yes.
Okay.
Please, Andrea, thank you.
Thanks, Lynn. Lynn took all my content, so I'm just going to talk
I'm
about
so
the.
sorry.
I'll just talk about the Stanley Cup playoffs for the next 20 minutes.
I'm sure you have plenty to say.
No, that was terrific. I learned a thing or two myself, and appreciate the local update. You guys must be gluttons for punishment if this is how you choose to spend your Wednesday night. So I'm going to start with a quick, funny story, because while I'm nerdy about this stuff, this is not a very sexy thing to be talking about at 7:30 on a Wednesday evening. So this might be the only thing you remember, and it'll keep you awake. So I spent my first 6 years working in management consulting, which is code for living out of a suitcase and sleeping in lots of Courtyard by Marriotts in places that are better forgotten. And one of my first experiences doing public speaking, which I still think about to this day when I look out at a room of faces staring at me or trying to stay awake, was a presentation I gave at the Cleveland Clinic, which is a large academic medical center outside Cleveland, world-renowned. And of course, I was very nervous, A, because it was the Cleveland Clinic and it was full of brilliant people looking for me to theoretically teach them something as a young, probably in their minds, wet behind the ears management consultant who didn't know much at all about their business. So I was standing there in this large auditorium because it's an academic medical center, and they do teaching as well as clinical education. They had this huge amphitheater that was full with probably 500 people that sloped up like you see in the movies. And in the back were emergency exits where people could file in and out as I was down in this pit preaching at them. And so I'm about 15 minutes into my long, rambling, boring conversation, and the CFO of the hospital, who was the guy who cut the checks to the consulting firm, was sitting in the front row, and he was kind of my guy who would either tell me to speed up, shut up, don't talk about that thing, and he would be sort of keeping me on pace. So I noticed about 15 minutes into my presentation that a steady green light has gone on above the back right exit door. So I make note of it. Nobody else seems to notice, and I look at the CFO, and he doesn't really say anything. So I keep going, rambling on for another 10 minutes. 10 minutes go by, and I notice that green steady light has now turned to a yellow blinking light. And at this point, there are other people in the room who started to see this. And this is before cell phones, so everybody was before smartphones anyway, everybody was sort of looking at their phones, checking their beepers. And I noticed that the CFO is starting to get a little bit agitated, and he's whispering to his colleagues. But again, he kind of signals to me, get through it, kid. So again, 5 minutes goes by, and I notice that the light's still flashing, but a woman dressed in street clothes sort of casually comes in that back upper door. And people have been coming and going out of the room, so I didn't think much of it. 10 or 15 minutes after, and I'm probably 15 minutes now away from finishing my presentation, that yellow blinking light turns to a red blinking light, and now the room is starting to freak out. The CFO stands up, goes into the hallway and takes a phone call. And about 5 minutes later, security guards rush in the back of the auditorium and hog grab the woman who had walked in to the amphitheater, and she starts struggling and screaming, and they sort of rush her out of the room. This, of course, puts a quick end to my droning presentation on like nursing recruitment and retention, or God knows what I was talking about at the time. And so the CFO comes up, like takes my lavalier mic, and basically says as politely as he can, like, meeting's over, we gotta go. So I look at him and I sort of say, I forget his name. Let's say he was John. I say, John, I noticed the light, but I don't work here. I have no idea what they meant. And he goes, oh, no, not your fault, Andrew. And he looks me deadpan in the eye and he says, your content was so boring, you kept that escaped psych patient sedate sitting in her chair in time for our security guards to come and remove her from the And needless to say, I was never invited to go back to the Cleveland Clinic. So hopefully, at least, I keep you slightly more entertained than an escaped psych patient at the Cleveland Clinic. I have 7 slides. I, unlike Lynn, require pictures to keep me grounded on the topic at hand. Like I said, there's definitely overlap between what I'm about to speak about and what she touched on. Hopefully it reinforces, anyway, some of the things she's talked about. I approach this, obviously, from a different perspective, right? I currently am employed at Cigna, I will say, because I work for a large public bureaucracy. These are my thoughts and opinions, not Cigna's. Cigna's does not endorse what are on these slides. In fact, I had to remove, as you will see as I go through the slide deck, any and all mentions of Cigna or logos of Cigna, because we're a big monster of a place. But of course, I do approach this from the perspective of a large Fortune 500 insurance company that has business in both the Medicaid market as well as the private exchange market. So I hopefully can give you that perspective. I also approach this from the perspective of someone that spent nearly a decade as a federal lobbyist in Washington, working for large Fortune 500 companies who were impacted by healthcare reform in various ways. I will say, as Lynn alluded to, many of them benefited greatly from the expansion of coverage under the ACA. And a lot of the work I did, even though many of these large companies didn't admit it publicly, was actually push for a lot of the things that expanded coverage in the ACA on behalf of them down in DC. So with that, I thought it would just be helpful. This is not meant to insult your intelligence. Like I said, you opted to come in here drawing content like this on a Wednesday night, so you're probably aware of this. But just to remind us all, what are the core elements that are in the ACA? Because I don't think you can talk about what's poised to change unless you understand what created the nexus of healthcare reform in the first place. So if the ultimate goal of universal coverage is the top of the pyramid, and of course we still are not quite at universal coverage, though we've made a big dent in getting there. We got there in 3 major ways, right? And if you go around the outside of the triangle, as Lynn talked about, one way we expanded coverage was to create marketplaces, which provided subsidies, cash payments essentially, for folks with moderate and low incomes to buy private individual plans. You'll hear people refer to marketplaces or exchanges. Those are the same sorts of things. That's Access Health in Connecticut, and every state, whether it was set up by the state or set up by the federal government, has a similar type of exchange. We also continue to have an employer-sponsored coverage model. That just means if you have a job and you get your health insurance through your employer, that's employer-sponsored coverage. The vast majority of people in the US get healthcare coverage through their employer, large or big. And that's actually Cigna, for what it's worth, core business is helping employers set up health plans. And then we also have, as Lynn touched on quite a bit, I think a huge expansion. I would say a once-in-a-generation transformational change through the ACA in how Medicaid eligibility was determined. She also alluded to the fact, I think very, very smartly, that there are a lot of misconceptions and misperceptions about who Medicaid serves. Frankly, I think that there's a misperception that it largely serves minorities. Not true. I think there's largely a perception that it only takes care of folks in long-term care. While that's true, that's not the largest percentage of the population. And then I also think there's a legacy perception that Medicaid is essentially for kids, independent young parents of those kids. Those things are all true, but what the ACA did was greatly expand this middle chunk of adults who may not have dependent children, who may not need long-term care, but who simply fall within a range just above the federal poverty limit, and who didn't previously have access to Medicaid, and now because of those expanded eligibility requirements through the ACA, they do. I also find, and I toyed with putting this statistic up here, can anybody guess what the federal poverty limit for a family of 4 is in 2016 dollars? Because I think that there are huge misperceptions when people talk about Medicaid expansion that we somehow have middle class or upper middle class people getting subsidies for health care. Anyone want to take a guess what the FPL is? It's a little higher than that. Yeah, it's in the low 30s. Someone said 32,000. It's right around there. That's for a family of 4. I don't know if anybody shopped for private health insurance with $32,000 in annual salary, and which probably includes a couple of kids. It's darn near impossible, right? So this idea that somehow, as you heard through the debate in the aftermath of the ACA passing, we were essentially giving middle-class families, giveaways to buy health insurance that they could otherwise afford on their own is just plainly a myth, right? So these are the core elements of the ACA. I think it's good to just remind ourselves what the ACA actually did, because we seem to be in a new age of misinformation, to put it mildly. So why did we do all of this in the first place? Well, we did it for a number of reasons, but to me, the biggest reason we did it is because we had about 40 million Americans with no health insurance. This pie chart is kind of overly complicated, but essentially what it shows you is that if you don't count if you look at just the non-elderly, which is an inartful way of saying people that don't qualify for Medicare, you had about 20% of 260 million people who were uninsured. That's that black segment of the pie. If you do the math, that's somewhere around 40 million Americans. Now, you may just have a problem with that, being we're the richest Western nation on the globe, just from an ideological standpoint, but the real economic reason why we did this, linked to this, is because having 40 million people running around with no health insurance is really, really expensive. When you talk about what's driving up the healthcare costs, yes, large monster insurers like Cigna could take part of that blame. Big medical device companies and pharma companies, many of which I intersected with, could be to blame. But a big driver is that we have a big chunk of people who use the ER as their healthcare service provider. And the problem, of course, is that healthcare essentially an inevitability. Everyone at some point, even if it's just them dying and needing to have a hospice care, everyone's going to avail themselves of some sort of health care, right? So there's no way escaping that when you have 40 million people running around with no coverage, that drives up costs. Premiums that we all pay through employer-sponsored coverage drives up costs for the Medicaid program, et cetera. So to me, again, that's a reminder. That's where we were in 2010. And that number was going up, not down. And it was actually going up precipitously because we were in the depths of the worst recession since the Great Depression, and more people were finding themselves without jobs, and therefore they didn't have employer-sponsored coverage. So we had a critical problem that needed addressing, and I actually get quite frustrated when folks debated the relative seriousness of Obama using his political capital back in 2008 to pass health care. Many suggested he should have done something else instead. I think it's easy to Monday morning quarterback that, but I actually saw this as an economic issue at its core. So did it work? Again, we can and do probably ad nauseum parse the imperfections of the ACA, but if you look at just this core thing that I think drove much of its passage, yeah, it worked. This is recent data, and we now have an uninsured rate that is below 10% for the first time ever, at least since the data's been being kept track of. And in states like Connecticut, where we benefit from having a relatively prosperous society, it's closer to 5%. So yeah, it worked. Did it do all of the things it promised to on the accelerated timelines, which politicians seem to like to attach themselves to? No, but it certainly took a big whack at this, which I think is important for lots of reasons. Of course, there are problems with it, right, to be fair, and a lot of this uninsured rate is linked to, as Lynn suggested, big increases in Medicaid eligibility and uptick. A lot of promises were made, I think incorrectly, by the CBO and others, who projected that a lot of the uninsured percentage was going to be chipped away at by exchange growth. People not availing themselves of Medicaid, but using subsidies and going on exchanges to buy private insurance plans. Didn't quite work out that way, and I know that that's a bit of an eye chart for folks not in the very front row, but what this shows you is that across the United States we have a real problem with private health plans offering plans on the exchanges, because the economics, frankly, just don't quite work. And I'll speak to that in a minute, at least from Cigna's perspective. But essentially, the darker the blue means that they have 3 or more insurers on average on the exchange. The lighter blue and yellow mean they might have only 1 or 0. And here in Connecticut, as was already talked about, we only have 2 now. We've ebbed and flowed between 2 and 4. Cigna, for example, was initially not on the exchange, then they did offer an exchange plan. Now it looks like they may opt out. And all of that is tied to sort of the misincentives and disincentives that I think make it really hard to operate profitable plans on those exchanges. So this, I would say, is a fair criticism of the ACA, because no one anticipated, I don't think, that much of the uninsured rate was going to be decreased, was going to be linked to Medicaid expansion, as it turns out to have been. I would also say, and I know I don't have unlimited time, something that a lot of folks don't realize, though again Lynn touched on it, not to keep saying that, part of the reason the Medicaid expansion has blown up as much as it has is that, again, we have what I would argue a once-in-a-generation public policy problem, which is we have an explosion in what's called the dual eligible population. Folks who are over 65 and therefore qualify for Medicare, but who are also so poor that they also qualify for Medicaid. No one anticipated that. For reasons you can imagine, right? The idea that we would have people qualifying for Medicare but still not being self-sufficient enough to afford their costs was never dreamed up by anyone making policy. So now you have this explosion in people who qualify for both programs, and no one has really figured out how to service that population in a way that doesn't break state and federal budgets. So a lot of this uptick in Medicaid expansion is because we have about 10,000 baby boomers turning 65 every single day, if you can believe that statistic. And about a third of them don't just get a Medicare card, they also get a Medicaid card, which again, no one anticipated. So really quickly, again, an impossible chart to read, I apologize, I'll talk through these briefly. What would Trump or Paul Ryan do? Again, we are in a period of flux, so I say all of this is with a bit of an asterisk, but this is the original CBO analysis. I wasn't quite as on the spot as Lynn in capturing the newest CBO analysis, though like she said, it's really shades of gray. Most of the things that are bad and good in the new bill are consistent, right? So across the top, I think Trump-Ryan care would do about 5 things. This is Kaiser Healthcare's analysis. If you haven't been to kff.org, it's my Bible for stuff like this. Kaiser is a not-for-profit, nonpartisan. If you're not using Lynn's organization for data, I would use Kaiser.
Kaiser is unparalleled.
Yeah,
it's wonderful.
I love it.
Yeah.
Kaiser, through CBO analysis, says the number of uninsured would go up by about 24 million, as Lynn said, if the current version of Trump Care passes. The initial consumer impact is that premiums would go up somewhere between 15 and 20%, and I will talk about why that is. Another consumer impact is that deductibles will rise, and that's linked, of course, to the damage it's poised to do to the private market. On the bottom side, yes, federal spending would go down. That's real easy to do. If you just take a big stick and slash Medicaid, federal spending goes down. Sure. Of course, the goal of our healthcare system should not be to get it to have federal spending minimized as a singular approach. It needs to be, I would argue, covering people in an economically efficient way. So sure, federal spending goes down. That's the easy stuff, right? And the impact on the federal deficit is that it will decrease the deficit marginally. But of note there is that it will actually decrease the budget less and less quickly than if we just left the Obamacare alone. So I think what we'll see if some version of this monstrosity passes is there'll be a lot of grandstanding about the impact on the federal deficit with no mention that actually we are shrinking the deficit less than if we did nothing and left Obamacare in place. Again, the big way we get to the bottom left, which is the big decrease in federal spending, as Lynn said, is we simply slash Medicaid to bits. And the biggest way we slash Medicaid to bits is we essentially turn it into a state block grant. You guys have probably heard about that. What is a state block grant? Basically, it's doing what this graph says. Right now, current law is Medicaid is a state program for people under a certain federal poverty limit that we talked about earlier. Today, that cost is split about 50-50 between the state and federal government. The federal government's piece reflects increases in healthcare costs, demographic changes. If the unemployment rate goes up, the federal government chips in more, et cetera, et cetera. It's a flexible spending formula. Conservatives in Congress hate that because they can't predict exactly what the program is going to cost. So what a block grant does is it says, no, we are no longer going to see Medicaid go up and down as the beneficiary popularity changes. We're just going to get a single chunk of money that doesn't change. We don't care if your enrollment goes up. We don't care if your uninsured rate goes up. We don't care if your number of beneficiaries go up. You got X amount and you're not getting a penny more. Fine, right? That'll very easily and predictably slash federal spending. What it will also do is it's going to force states to do things like trim eligibility and coverage, because it will be the only way that they'll be able to stretch those dollars in the ways that they do now. And we don't have to guess about that, because there have actually been a number of conservative states that have used a lot of pressure already through Obamacare to push for increased flexibility. Right? This is sort of a conservative talking point, is that we want to have the states make these decisions because they're best suited to make these decisions for their local populations. That's just frankly a bunch of BS. What that means is it gives the states the ability to trim benefits and use the money in other ways. And we can look at states like Texas and Florida who have been given that increased flexibility, and that's exactly what they do. They don't improve outcomes or increase eligibility. They trim the minute they get the green light. So this is really dangerous for all of the reasons that Lynn talked about. Even if you think philosophically that we need to do something to rein in Medicaid costs, this is not the way to do it. There are other ways to do it. We don't have enough time to talk about it. But doing it with this sort of blunt instrument, frankly, is just dangerous and irresponsible public policy, in my opinion, period. So again, what's the impact on private health insurers? This was my one slide that I think speaks to at least the view of an organization like Cigna. I won't talk about Cigna because I want to keep my job, but I can tell you that Aetna, which is our biggest competitor and who has struggled, as Cigna has, to offer plans on the state exchanges, Aetna released publicly about a month and a half ago that they lost in 2016 $900 million servicing about 1 million distinct beneficiaries on the 12 insurance state exchanges that they serviced. So you can imagine why private health insurers are dropping off of that multicolored map that I showed you about 4 slides back. It's really, really tough to make money on these exchanges. And again, we don't have enough time to get into exactly why that is. However, as Lynn said, another brilliant idea that the Trump administration has is to remove these subsidies that they pay to private health insurance companies like Cigna and Aetna to offer these plans. Those are called, I always forget the cost sharing reduction or CSR payments. All that is basically the government bribing private health insurance companies to offer affordable plans on the exchanges. Trump has, as Lynn said, is toying around with removing those. If those CSR payments go away, this is what Kaiser predicts will happen to premiums. They will go up on average about 15 to 20%, which is in part why, when Lynn was walking through the rate increases that the insurers like Anthem, who are on Access Connecticut, are asking for, they're planning for this. And you could argue that they're doing so too prematurely without enough information, and they're probably hedging a bit and doing other things. There are other factors at play there, but it's not a coincidence that they're looking for rate increases around 20%, because they know that if these CSR payments go away, that's what they will have to charge to just be back at baseline. So again, taking away the cost sharing payments, dangerous, irresponsible public policy in my opinion. So in summary, and I know I've gone over my time, I apologize, Dr. Rich. Really quickly, Obamacare reduced the number of Americans without health insurance coverage, and it did it in 3 ways. We expanded Medicaid eligibility. We offered subsidies for the purchase of private plans on exchanges or marketplaces to companies like Cigna and Aetna and Anthem. And we mandated coverage to ensure healthy and younger people are in the system. 2, Obamacare also created a range of programs to try to rein in healthcare costs. I didn't talk about those a lot because we don't have time. But when I mentioned that Obamacare was actually slated to reduce the budget deficit, it was poised and is doing so today exactly that, by doing some of these things. When people talk about this bending of the cost curve that you hear, while that hasn't happened as fast as everybody would have liked, it has done things like start to shift the paradigm from paying clinicians and providers for volume. The more things they do, the more they get paid, fee-for-service system, to one that incents care quality, and I know Dr. Rich is going to talk about that. It created accountable care organizations, and like I said, those things and a range of other pilot programs have begun to bend that cost curve and actually save the Treasury buckets of money. And finally, Trump in RyanCare seeks to lower federal spending and baseline premium costs. That's the soundbite, but it does that, I would argue, in extremely dangerous ways. Massive reductions in Medicaid funding. The only outcome of that, inevitably, is going to be we're going to see cuts to benefits and access. It reduces subsidies that insurers like Cigna get to offer affordable plans on the exchanges. It lifts coverage mandates, which is immediately going to change the population mix and ensure that we don't have anywhere near the amount of younger and healthy people we need in the system to balance it. And it theoretically is giving states increased flexibility to opt out or in of many of the popular Obamacare benefits. When you hear Trump say, oh no, my plans all cover pre-existing conditions, nobody with pre-existing conditions will be locked out, that's simply a lie, period. We should start calling lies lies. Yes, there is language in the bill that maintains pre-existing conditions, and then about 20 paragraphs down, there's a big asterisk which says, yes, but the states can apply to opt out of those if they want to, which many of them want to, which is why it's in the bill, and they will do that. I'm out of time. That's all I got. Thank you.
Good evening. I will try my best to compliment the speakers before me. We all prepared pretty quickly, so we didn't have the opportunity we usually have to coordinate everything. So you'll have to pardon me if I jump over some slides because you've seen them before. By the way, I'm glad to make these available, my slides available to candidates if any of you want them to be distributed by email. I think you'll find, what I find is I look at these issues and deal with these policy issues. Obviously, they disgust all of us, and we have a lot of emotions. But the best thing we can do is, well, maybe try to. Oh, wait a minute. There we go. Yeah, now he deserves a hand. But I think the best thing you can do is what you saw.
You need to put the USB in your computer, which you're
Oh,
on top of it.
on talk for a second. What you saw our first two speakers do, and that is come prepared with facts. Sometimes it's tables, sometimes it's numbers, but the pithier you can be, the better you can have these arguments. So I'm just going to start off with a very brief story, and it's not funny at all. When I began my clinical career, I was an emergency physician in downtown Washington, and that was in the 2 or 3 years before the federal government actually mandated that hospitals not transfer people out of their ER, basically called patient dumping. So I was in down Washington at 2300 Pennsylvania Avenue, and of course you can guess that being there, we saw a lot of people who lived in inner city Washington, particularly in those days. It was a pretty rough city, a lot of people who were down and out deprived, and lots of congressmen and staffers and others all coming into the same emergency department. And I can assure you they had a very different experience because back then when I started, the law did not require us to admit people to the hospital. They would get sent to the city hospital where the care was horrendous. They eventually closed that hospital. But that's the danger I see when I see what's going on right now. It's destroy all the social systems, destroy the insurance that let people get care where they wanted to get care and where they were welcome to have their care, and throw it all at the wall at one time. So I'm going to talk less emotionally and more factually. I'm going to run through some of the same things, but I will jump over things that you've seen before. And this whole concept of repeal and replace is ridiculous because it's really a bait and switch or substitute game that's going on, even though by law they need to replace. So you might recognize the top. Some of you might recognize this. This got picked up by the news about 3 weeks ago. And it's a little hard to see, I apologize. But basically it's a chart of the US showing the life expectancy. The red is shorter life expectancy, the darker blue, which fortunately we get some in our area. If you look in Connecticut, you can get an idea. We have some dark blue. There's a 20-year difference in the United States in life expectancy. And the reason I put this up there is not to scare people or to say you lived 10 years too long, like some people might think in Washington right now. The point is that these things affect everybody. They don't affect, quote, select populations. And as was pointed out by Andrew, it's not a racial thing. It's not even necessarily a zip code thing. I mean, there's some amazing disparities. Why is healthcare so important? What's driving all this? Well, it's a huge chunk of the federal budget. And so it becomes something that in some ways seems like an easy target, particularly if you want to give tax breaks and find ways to pay for them. Healthcare is a big ticket item. It's the green line on there, and that's just federal government's fee. But the U.S. is not doing all so well. We spend, actually now it's about 18.4% of our gross domestic product. And this is not a graph we want to be above everybody else in the Western world. All the other countries of Western Europe and Japan and Australia spend way less than we do on medical care. I'm not going to go into all the detail tonight, but if you look at their total spending in medical care, the direct medical care you get from doctors and nurses and hospitals, and add to it the social services, the United States comes out at about 25% of our gross domestic product. That's right about the middle of the rest of the world. So we actually are not spending that much more. We're just spending it in ways that may not be the best. And then we're not investing in the social systems that allow people to be healthier And we're talking about transportation, decent food, jobs, schools, I mean, everything else except the direct medical care. And that's really a critical point when you look at, and Andrew touched on it in the short amount of time he had. I'm going to go a little bit more into some of the other things that the Affordable Care Act was trying to do. Part of that was increasing access by extending insurance through several methods. U.S. death rate, by the way, also, again, not a good place to be, way over there. We don't do as well. With all the money we're spending on medical care, we're missing. And in fact, it got worse this year. For the first time, the U.S. life expectancy mortality rate went up, and for almost everything but cancer, it went up. It's a scary thought, that we were running, since the HIV epidemic began in the early 80s, we've been on a roll where life expectancy has been increasing, and suddenly we seem to have crested, at least for 1 year. And that is pretty scary. For the first time, chronic disease, diabetes, heart disease, hypertension, stroke, renal failure, is actually the greatest worldwide threat. It's past infectious disease, because we've done pretty well. Controlling polio, smallpox, Ebola, almost completely controlled. But different things are going on now in our society that affect everybody. Again, it's not just the people directly threatened with losing insurance. People now actually probably or may have a shorter lifespan than their parents. First time that anybody remembers that in our history. 1 in 2, at least half of adults have one chronic disease or more. So it's stacking up. Diabetes is quadrupled in a generation and is at least doubling still. In the last study, half of Californian adults were either diabetic or pre-diabetic. Pretty scary. So, and children, of course, obesity in children and teenagers is frightening as to where that will go. But when you look at people who don't have the support services, if you are low income and have unemployment, housing instability, healthcare costs are 15 to 25% higher than other people because of those social factors. Social determinants is the more common term these days. So these things are all interwoven. And at the end, I'm going to come back, so I'm going to touch on some of the other budget cuts in addition to what Andrew covered on specifically on healthcare. Behavioral health patients tend to be 2 to 3 times as expensive because their medical problems, of course, are much more difficult for them to manage and much more difficult for the people that care for them to manage because of the behavioral health issues. And they get admitted to hospitals about 10 times more than other people without significant behavioral health issues. Again, this is something that goes through the population. It's not a matter of being poor or rich or black or white. And not having a primary care doctor alone people have a 12% higher cost, at least in one study. I bet it's a lot higher than that, but not having an anchor or somewhere to go and somebody help you coordinate your care. I'm not going to go through all these, but the U.S. system is expensive for several reasons. The first box actually are pretty good things. Joint replacement, immunotherapy for cancer, true treatment of hepatitis C, so it goes away. Costs $80,000 to treat, but it goes away. And so these are investments in the future that are well worth it. But then you get into access and the amount that we use hospitals. We admit people to hospitals and nursing homes here way more than the rest of the world, and it's the most expensive part of our system. All part of it I'm getting to in a moment with Obamacare, what we're trying to change. And then a lot of waste in the system, but that probably Obamacare was not going to fix. But I want to give you a couple of sound bites, and this is one of them. The Affordable Care Act was about transforming the system. The HCA is only about who's going to get stuck with the bill. You haven't heard a single bit of discussion out there about changing the healthcare system to actually reduce the cost over time. So it's really running into a wall. I'm not going to go through all of these, but when the feds put out the Affordable Care Act, these were all the parts of the act, and they translate into 10,000 pages of regulations. I think the bill itself was, 1,000 pages?
More than that.
Or 2,000. But it was 20,000 pages of regulations. There's a lot in there. It's not only about insurance. And a lot of it was aimed at what Andrew had referenced at the end, and that was getting to more efficient care, setting up structures so people have private personal physicians that they can go to, or clinics that are their home, where they can go and get their care coordinated. And switching payment around, and it's very complicated. Right now, almost everybody pays fee-for-service. You go to a doctor or a hospital, you get a bill, you pay it. The idea was now to group these together into what are being called accountable care organizations, where groups of doctors and hospitals get paid a certain amount per year to care for you, but they only get paid and only get paid fully if they meet the quality measures. So what Obamacare did was it tied the performance to the payment. The first time ever in our country that that's been done. And after 7 years, it was beginning to work. That was a lot of the work that I was doing in the last couple of years. It was really beginning to work. The home health people, the visiting nurses were tied to what was going on in the hospital and what happened after. So I think we hit a lot of these things. I just want to touch a couple, though, that I'm not sure what we hit. But Obamacare actually got rid of the age and pre-existing conditions. It extended coverage to kids up to 12, not kids, but young adults up to 26. That was a lot of people, several million, I think it was 7 million, not the exact number. But having the employer an individual mandate where instead employers have to pay a penalty and individuals have to pay a penalty if they don't get insurance was the way to make the insurance work. And that was to get enough healthy people insured so that the people who are not so healthy could get the subsidies that we talked about earlier. And then the essential health benefits, which we've talked about, mental health, prescription drug, maternity care. But the other really important part was setting up a lot of funding to test these new models. So they didn't suddenly just pass the law and say, everybody's going into accountable care and everything's going to change overnight. They've given out a lot of funding to get better information technology to help doctors and hospitals set up these groups and have tested them to see if they work. And so it's interesting, I'm going to jump over the slide in a second that shows the number of people insured, but this is really interesting, also from Kaiser, which is one of my favorite places along with Lynn and Andrew. But this graph actually shows for people of all different income brackets, so it's across the board, you see the same curve, and that is the percent of adults who report delaying or getting care, going without medical care due to costs. And the red line is when the Affordable Care Act happened. So it wasn't only affecting people who were on Medicaid and uninsured, it was affecting everybody. And this is just the uninsured, which I won't take time on. And so I think we've covered most of these. Again, apologies for doing that, but I don't want to take up more time if we haven't. But Andrew talked about the Medicaid eligibility going to, instead of buy what your need is based on a federal definition, it's now going to be much more up to the states. And they're going to get a fixed amount of money, so they could decide to give you more benefits, but there won't be money coming for it. Planned Parenthood, I think, again, there's something I want to clarify, I've been touched on before. There's been a lot of talk about, how the new act that Congress passed stops funding to Planned Parenthood. Is actually not a single budget line in the budget for Planned Parenthood. Most of the money they get, which is 40% of all their operating dollars across the country, is through Medicaid services. As mentioned, it's a lot of women get their only care there, so it's their primary care. And then there are some separate grants from a different part of the federal budget, which are much smaller, a smaller part of that, which are for family planning. And the Congressional Budget Office actually calculated this, I found this number last week, that the government saves $7 in direct Medicaid-related costs for every dollar they invest in family planning, because they're paying for the children, the births and the children anyway. So even if you look at it in raw dollars, there are returns. The pre-existing condition, again, Andrew hit that, very important point, that it's in there, but the states can request a waiver and not cover pre-existing. And that was somewhere around, prior to Obamacare, the calculation was 6.3 million people have substantial pre-existing illnesses. The other is the age tax, which affects a lot of people. And that was before you could only charge each age group the same amount, but there's a multiplier from young to old that was 3 times. That goes to 5 times, which means if you're not yet Medicare eligible and yet you're in your 50s or 60s, young 60s, you're going to be able to be charged up to 5 times the base that the insurance is being sold for. One good thing is, I guess, they increased the HSA contribution limits, but I guess it's not really a big deal. But there's uncertainty and instability is a huge issue. Which again mentioned earlier, with the Trump team keeps asking for delays. They're intentionally disturbing the marketplaces. It's why Cigna and why other companies don't want to play or find it very hard to play in the marketplace, because they don't know if they're going to get the subsidies, and that's why it's a 20-something, say 50 to 50-something, because they don't know what money's going to be there next year to pay for the people with more complicated illnesses. The state waiver option, again, you're welcome to send the slides around. Many things can be waived. We did all of them in discussion. The other thing they threw in, again, to satisfy the conservatives, was that insurance policies can't be eligible for any credits under this plan, if there really are any, if they include abortion services. So they threw in that piece a couple of times in the act. So I'll leave it with, are we talking about thoughtful change or just across the board cuts? I think most of you know where I stand on that. We mentioned Kaiser Foundation, Commonwealth Fund, and Health Affairs blog are two other great sources for information. So one very last closing thought, and I'm not going to go through all of this. Well, my point on this is, even though we, for many good reasons, are focusing on Medicaid and the poorest in our nation and their health care, the cuts hit the CDC at the tune of $1.3 billion. The chronic disease programs, the diabetes, heart attacks, all the things I talked about before that are killing us slowly, or not so slowly, HIV/AIDS, hepatitis, sexually transmitted disease, TB, and disaster response, all slashed at huge, hundreds of millions of dollars in this budget. The CHIP program is a 20% cut. The CHIP program is a program for children to be sure they get, there's a lot of services, including medical, dental, glasses, and I believe some other things. The SNAP program, I don't know the exact dollar amount, that's food stamps, is slashed horribly. So they're basically attacking every bit of the social structure that would normally support the medical care. It's all being thrown at once. That's just for a big bright red. So again, you remember this is how ugly it looks just for Medicaid. So with that, let me stop. Thank you.
So I'm Ellen Graham. I am a community liaison for Senator Blumenthal. So I like to say I'm his eyes and ears in the state. As much as he wants to be everywhere, and he does try to be everywhere, he can't always do it. So I have different issue areas. I do healthcare, education, environment, women's issues. So nothing really important going on with those. So we've been very busy, and we've been getting a lot of calls at our office, and we like to get those calls when people call us saying, that we're doing good things. So I do work on healthcare in the state. I'm supported by staffers in DC who are living and breathing the healthcare right now. But the good thing about going last is, these panelists have really covered a lot that I would have said. So I just want to kind of comment on where it is right now. The Senate has a group together, so they're all Republicans, 13. Last I checked, they were all men. They may have added a woman senator, but I don't know about that, and they're coming up with their own plan. And they have to pass this plan by the end of the summer because it's part of the budget, and it's part of this budget year. And then if they pass it by the end of the summer, they only need 51 votes. If they go over that time, it's a new budget year, and they'd have to do a different, they need 60 votes. So they're rushing to get something done, but they can only lose up to 3 of their own party. And they have some moderates, and they have some not moderates, so I think they really have a hard kind of task in front of them. And so that's kind of where that is. I don't have any sort of inside information about what they're doing. They don't share it with the Democrats, so we don't know what's going on in the Senate right now. So that's kind of my update. I'm sorry I can provide more, but I can try to answer questions or anything like that.
And we have time for questions, so if somebody has questions for the panelists. Please.
What do you think is going to happen in Washington with Medicare?
Medicare, I think...
is that voucher system that was mentioned, how likely do you see that? And if not that, what else might happen?
I'm not sure exactly what's going to happen. I know the senator is very committed to, Medicare and keeping Medicaid funding. He said many times that the bill is dead on arrival, and he's going to try his hardest. I don't really know what's going to happen with that.
I think it's one of those things that's been bandied about. It's certainly something that Paul Ryan and very fiscal conservatives have put out there. But I always remind myself about the voting power of the 65 and older population, and it's, you know, as a population, that group votes, and they have time. A lot of them. I'm soon to be there. In 5 years, I'll be there. But you know, they have a lot of time to go to town hall meetings, to, you know, engage in fighting. So, and they have very powerful lobbies for the seniors. So it's a much less palatable group of people for even fiscal conservatives to want to cut. And in fact, many people who are very troubled by what's happening in the healthcare debate point to, rather than decimating the Affordable Care Act, we should be moving in the direction of, some people like Bernie Sanders, you know, said Medicare for all. There are some people who are talking about a phase-in of Medicare coverage for populations over a period of time. So you would gradually add more and more people into a very successful program that has done a lot to control costs and talk about care, you know, quality of care. So you could start by, you know, bringing everybody 55 and older in. Or there's another proposal that's out there about Medicare by choice. So that basically in the debate, that would be called a public option. You know, so if you don't like the private market, if it isn't working for you, or you know, you want to figure out a way to buy into a public option like a Medicare at a younger age, that might be an option to go for. There are a lot of people talking about that. In fact, Kevin Limbo, our state comptroller, who used to be our healthcare advocate, who understands healthcare better than a lot of people up in Hartford, has, you know, actually just was quoted in the Hartford Business Journal in the past day or so, talking about a phased-in Medicare for all program. So, you know, there are people talking about taking it away, but there are people talking about, oh, that might be the way we get to taking care of people by expanding that gradually over time. So there's two distinct sides to that debate.
Thank you.
In regard, and I don't know who can answer this question, if anyone can, or make a supposition about it. In regard to pre-existing injuries, if it goes back to the state can decide, what happens if 5 states decide to do it and the rest of the states say no? And I've heard that pre-existing injuries would go as far as if a woman doesn't have health coverage and becomes pregnant and then gets health coverage, that's a pre-existing injury, so that's not covered. Has anyone talked about the fact that what if 5 states buy into this, which I would imagine would be the Northeast, and the rest of and maybe California, the rest of the country says no? What happens then?
I'm happy to at least
Go ahead.
start. So, great question. And the answer to your first question, can certain states opt in and others opt out, where you create a scenario where certain states decide to maintain coverage for those with pre-existing conditions and others don't? The answer is yes. That is likely what would happen, which is exactly what we saw when Obamacare was passed and we saw this big expansion of Medicaid. You saw certain states, mostly those that lean Democratic, opting in to expanding their Medicaid programs, and many Republican-led states opting out. And in fact, that uninsured rate that a number of us showed going down would actually have gone down significantly more had those 20 or so holdout Republican states actually taken the free federal money and expanded their Medicaid programs. They mostly didn't for ideological reasons. So that's probably exactly what you will see. Now, to be fair, though, I think it's all a bunch of hogwash. What the Republicans will say is the way they will cover people with pre-existing conditions is by recreating something that's called high-risk pools, which, of course, again, is a bit of sort of voodoo healthcare policy, which is not a new idea at all. In fact, Connecticut, I think, was one of the very first states back in the 70s to try to implement a high-risk pool. What a high-risk pool is exactly what it sounds like. It's this sort of ugly stepchild healthcare plan for people that are massively unaffordable and that no one else can figure out how to make money taking care of, who gets sacked with bare bones health insurance plans at massively high costs and massively high premiums. They've never been shown to work, with the rare exception of states that essentially overfund them above and beyond what it would cost to simply cover those same people in Medicaid, meaning that there's no financial advantage to doing it. What the Trump Care, Ryan Care bill does is it proposes seed money of about $50 million with an M dollars to start high-risk pools in states that opt out of covering pre-existing conditions. For perspective, the only high-risk pool that was ever seen to be even vaguely effective was in Minnesota. Minnesota alone, over a 10-year period, spent $1 billion with a B, and that was 15 years ago, before they expanded Medicaid and no longer needed their high-risk pool. So my point in saying that is that while 50 million sounds a lot to the average guy on the street, and while this notion that you cover people in high-risk pools sounds sensible, it'll be underfunded purposely, so it doesn't work. And it's not a solution to figuring out a way to cover people that have pre-existing conditions. So, long-winded answer to say, yes, if it's something like that passes, you will see a patchwork of states that do and don't cover it, and you will see a myth propagated that high-risk pools are taking care of everybody, so don't worry about it.
There are states that also have more essential health benefits in their plan design, in their health care plan design than other states too. So, for example, when Access Health CT, our exchange, was trying to figure out, that the Obamacare required certain things in an essential health benefits package, but some states are more generous than others, and Connecticut certainly has a long history of requiring coverage for more things rather than less things, because each year at the legislature, and I've been a registered lobbyist since '86, each year at the legislature there are lists of things that different special interests come up and want to have included in mandated coverage and things of that sort. So one thing is, people make the argument, the insurers, and I think rightly so, make the argument, the more things you add that need to be covered, that's going to somewhat drive the cost of the care. But it's very hard to say to people, if they have certain types of pre-existing conditions, that they shouldn't get coverage for them. And what we call it in our office are crappy plans, and that's what, when you're talking about the high-risk pool that we used to have in Connecticut, it was crappy coverage. You basically paid a lot of money for something that didn't really take care of you the way you needed to be taken care of. And in our mind, the idea of healthcare is care so you can get the care you need when you need it at a price you can afford.
Let me just add two quick things. One is, since we're in a before and after scenario, you can actually get numbers on a lot of these things. And I believe the number for I think it was 6.7 million people were directly affected by pre-existing before the Affordable Care Act. And there's, many horror stories, and there's a lot of different answers when people have asked congressmen what they thought they voted for, but things like women after sexual assault, whether or not the mental health issues would now be considered pre-existing, whether getting prophylaxis treatment for HIV, you now would be marked. And there are stories like that from before. Again, usually from the kind of crummier, smaller health plans, not the big and more upstanding health plans. But these stories are really frightening. And then one last thing, the waiver, I came across this the other day, it was kind of interesting. I thought the waiver was only dark and evil, that it was brought about to skirt things. It actually came out of the Kennedy from Kennedy, who wanted to help states to be creative about how they brought social programs into being. And so the idea was that if the state could come up with something that really made sense and made economic sense, they wanted to encourage that. And now it's been totally warped into a way of, you can say one thing and put wording in and point it out, and suddenly it really means something else because the state now comes up with a waiver. So very.
There have been some states, Maryland, Washington, Oregon, Wisconsin, that have done some very good things with waivers. They've had progressive ideas about how they can improve care for people and gotten waivers for positive things. But the point is, you have to get a waiver from the feds, and to take federal money and spend it slightly differently in your state. And given who's in charge of HHS right now and who's in charge of making the decisions about the waiver, it's not like very likely that you could say, oh, we want to do, like Vermont wanted to do single payer for Vermont. Like, you can't compare states because they're all so different. The marketplaces are different, the populations are different, whatever. But they wanted to do single payer, and they would have had to get a waiver from the feds in order to take their federal money and use it differently. So they decided not to pursue it because they figured out it was going to cost them more money than they could afford. But there are lots of ways you can use waivers positively. But right now, people are loath to talk about them because they feel like it's only going to be used by people who want to take things away from folks.
I would also add, because I know this is all really terribly depressing talk, just for perspective, Mitch McConnell today, majority leader in the Senate, was quoted as saying he's not quite sure how they're going to get to 50 votes, right? The optics of him saying that aren't terrific. So, I think that there's a good chance, right, that a lot of what we're talking about is moderated or not passed at all. And so I don't want to I hope none of us are giving the impression that all of this is a done deal. That said, I don't also want to create complacency or sugarcoat stuff, because I think the way we keep the pressure up is by being very realistic about what the worst case scenarios would be. But I think it's very questionable if anything passes the Senate that looks anything like these scenarios that the administration and Paul Ryan wish would pass.
I've heard of, Trump has said he wants Obamacare's going to blow up. So do you think the CSR that you're talking about, the cost sharing, needs a little known? I was wondering if the CSR is a cost sharing reduction. Is he doing that on purpose to make the whole exchange blow up?
What do you think?
Yes. Some people believe that this lollygaggling that's going on around the cost sharing reduction is intentionally throwing the markets into disarray. Because you remember he was quoted earlier this year saying the markets are a mess, they're falling apart, whatever. It's sort of a self-fulfilling prophecy if you keep, doing things like saying you're not going to enforce the individual mandate. My son, who's 27 years old, who finally is earning enough money that he doesn't qualify for a subsidy in the exchange, it's going to be pretty hard to tell your 27-year-old that he should be paying $350 a month for his premiums and pay a $6,000 deductible if he's feeling pretty healthy and he's told that the individual mandate isn't going to be enforced. So, if you start doing stuff like that to the marketplace, and it's reflected in how many insurers are willing to stay in, hang in through it.
I do strategic planning at Cigna, and you can imagine what's being talked about as we attempt to strategically plan for the markets we're going to be in and out of. And we've gotten to know our government affairs and lobbying folks better in the last 3 weeks than I think many people did in 20 years at the company, right? So, and then I would also say, and I think Dr. Rich wanted to chime in too, that this idea that the market is exploding and that Obamacare is imploding is a bit of a hide the ball thing, because in reality, the number of people that gained access to coverage on the exchanges pales in comparison to the folks that gained access through Medicaid, right?
Right.
So to frame Obamacare,
it's less than 100,000 people in Connecticut are getting their coverage through the exchange.
So this idea that he equates Obamacare to the struggles on the exchanges misses the reality, which in reality, Obamacare is more about expanding Medicaid eligibility, which it's hard for anyone to claim would be imploding or is broken, because many people that are on Medicaid are actually quite happy with it. Medicaid is run more efficiently than many private plans. They spend less on administrative costs than many private plans do. So not only do I believe, yes, he's doing it on purpose to destabilize the market, it also is simply kind of a half-truth in the sense that he's framing Obamacare only through the lens of the exchange, when that's actually a small portion of what the bill does.
That's fine, go ahead, you covered it nicely, let's.
Well, that begs the question for me, okay? If Medicare is cost efficient, and I'm on it, and I can tell you, I love being able to go wherever I want to go to get my care, okay? And Medicaid is equally cost efficient, and people love it. Why do we have insurance companies? Okay, why don't we just have a publicly funded thing? And yeah, it's going to provide a certain level of coverage, and then I go get my supplemental, okay? And you know, at least I got something if you guys price me out of everything, you know, the extras,
Yeah.
you know? Because that, I was on Obamacare for 18 months. I was retired early and got stuck, you know, kicked off of my husband's plan, and bingo, I was there for 18 months and I didn't have any insurance. And I gotta tell you, I had to go to Rockville to see a doctor. I mean, there are, when you're on those plans, very restrictive things. And, you know, I had Blue Cross Blue Shield, and it's kind of like, there's a disclaimer at the bottom of the screen where you're searching for your provider that says, oh, this list might not be up to date. And then so you call the number and they tell you to check the website. It's like, I just would call and say, I want it recorded in my thing that I talked to you and you said this doctor was covered. And then after I went on Medicare, I started getting letters telling me that doctors that I had services for were not in network. It was the most awful 18 months of my life. As somebody who was on a corporate plan all my life, and for any of you who have employer insurance, you have no idea. You have absolutely no idea what that other half of the world puts up with. And maybe the doctors do. They do because they deal with it.
The health insurance
It's like,
lobby.
why do we bother?
The health insurance lobby opposes this, right? Which is interesting. So the large lobbying group, which is an acronym that's called AHIP, which represents Aetna and Cigna and United and Humana and all the large commercial plans, vocally opposed to Trump Care, right? So
The hospitals are opposed.
hospital opposed. But to your point around why do we have private insurance companies? I think what a lot of folks don't realize, and frankly I didn't realize until I joined Cigna, the large commercial plans make most of their money not on employer-based plans that they sponsor through employers. They make most of their money on Medicare Advantage and supplemental plans, like add-ons, disability, life insurance, dental, vision.
And administration, I'll bet.
Right. And so when Mark Bertolini, the CEO of Aetna, came out, I believe either Friday or Monday, and said we should have a conversation about universal coverage,
Yeah.
a lot of people thought, no kidding, because basically the large commercial plans don't make a lot of money on their employer plans anyway.
Plus, you
So-
guys know you're going to be administering it. If we went to a Medicare for all, I mean, you do it already. Why won't you continue to do it?
Let me throw something, I mean, and I couldn't agree more. But if you look at several of the countries in Europe and Scandinavia, they all have different systems. Some have, I mean, Israel has 4 companies and you have to buy insurance from one, but the rates are set and flat, and the government subsidizes the difference. So if we can't get past what's going on now, we don't have a prayer to get to anything that's even more level. I think, you know, right now it's just this crazy uphill battle to even get to some of the equity that was created under Obamacare through these subsidies.
Well, and when you think of all the money we're spending on healthcare, as you saw in the charts that were shown about what we're spending relative and what percentage of our GDP we're spending. And if that keeps climbing up, I mean, I'm a local elected official. I have to do the budgets for my town. If the cost of healthcare benefits keep going up, there's less money for other things like schools, classrooms, parks and rec, all that kind of stuff. And I don't know whether people know this, but over 50% of individual bankruptcy filings are due to medical debt. So it's a solid economic issue that needs to be dealt with.
This gentleman here is trying to ask a question.
Is there an action plan, like the Republican senators who are on this committee? Is there any value in going and protesting in their state? Is there a way to move? So if Blumenthal is not there, what is the action plan to target those 13 senators to have them hear our voice? What would the 4 of you propose as an action plan?
I would say contact your family and friends who live in those states make sure they know what's going on and have them contact their, and it's always good. We like to hear from people and what they're thinking. So if you are against whatever bill, let us know. Even if you think we're there with you, it's because the senator knows what's going on. We tell him, you know, these people have called about this. We're getting a lot of calls, and it really impacts his decision making.
I mean, all of this, there's just a whole lot of impotence.
It's very hard if you live in Connecticut because our delegation is good on this, right? So a lot of people I talk to are frustrated. I agree with what Ellen said. And we asked all the members of our congressional delegation for the Protect Our Care thing, what would you like people in Connecticut to do? And the answer across the board is have them call us and tell us they like what we're doing and to stand up, you know, to just keep standing up against those forces down in DC so that we can say on the floor, I've been getting calls off the hook from people that have been saying this, or here's Sherry's story about how she would be affected by what you're suggesting to do, Mitch McConnell. And then the friends and family strategy is really, you know, about the only thing you can do if you live in a state where, you know, if you wanted to, there are demonstrations and actions going on in these target Senate districts. I mean, you could travel up to Maine and, you know, try to keep Susan Collins, you know, in the right place. She's one of those moderates who might, you know, go to the right side on this. So, you know.
I'd anonymously start sending New York Times subscriptions to all of your Republican.
Washington Post.
That's a good one.
They put them in their birdcage.
There's a lady back here. Do you still have a question?
I just wanted to know if there's any coordinated Democratic effort to have a proposal to improve and revise the ACA, seeing that Trump care probably won't pass. Is there a nice proposal?
I have not heard of anything. I mean, since the Senate is Republican-led right now.
Right, but
you know, that's a great question.
yeah.
And it's something
There are bills in Congress, but they're more along the lines of single payer or
Right. And this isn't gonna happen right now.
Medicare for all. I think there are a number of Democrats in Congress who have said we should be talking about fixing the ACA, doing the things that the Republicans blocked them from doing when they gained control of the House and Senate. You know, let's remember when Medicaid and Medicare and Social Security were all passed, they were fine-tuned for years afterwards to get it right, and still probably need to be fine-tuned. So this idea that you pass a law in 2010 that's like massively complicated and then never go back to tinker with it at all to fix it is ridiculous. Maybe if they fail, they'll open their eyes to doing this. Who knows? But it's going to take. There's no plan.
Democrats should have something. You know how the Republicans repealed it 43 times or whatever and have nothing to replace it?
Right.
The Democrats should have something ready, and it's a good talking point, no matter
Right.
whether they own the House or not.
Absolutely. And I think in all fairness, a number of Democrats have ideas about what they would do. You know, there's been much written about what you would do to fix the ACA. And people know what they are. There just needs to be the ability to have that discussion.
Who would be a good leader? Would Senator Blumenthal be in?
he could be a leader. I will definitely
Bring that back.
bring it back to him, and I will talk to him about that. He's going to be in the state. They all have a recess this coming week, so he'll be around. Probably maybe see him a few times.
Similar to that question, I was wondering what your thoughts are on what's the answer to these insurance companies pulling out of the exchanges? Like that's been such a challenge with the ACA. I know you probably don't have the answer anyway, but what are some thoughts on that?
I mean, from the perception of a private insurance company person, the biggest problem is actually not the amount that the CSR subsidies are, it's the lack of participation. There aren't enough bodies to make the math work. I mean, there are, I'll give you one state, I believe this is public knowledge, it better be since this is being filmed. I believe in Maryland, which is an exchange that Cigna has been in since the passage of the ACA, we right now have 1,000 beneficiaries in the entire state. That doesn't work, right? So I think part of it is you need more bodies in the exchanges, and that's a mix of tinkering with the subsidies that are provided to the beneficiaries, not the ones provided to the insurance company. And it's an awareness and marketing piece. And it's, you know, we talked a little bit about this individual mandate. The reality is the individual mandate was not being enforced. So you have to enforce the mandate if you're going to have a mandate. And that's what gets people to say, I'm not going to go buy, you know, the new Xbox. I'm going to like get an insurance plan. So
That's going to keep my son.
right. He struck me as a gamer for some reason.
No, he wasn't allowed to have video games when I was growing up.
Mary Ellen.
Yeah, it looks like more and more this is going to go to the states to make their own decisions. But how do they have a formula in place? Or is it going to be based on population? And if the state gets it, so much money per person, per age level or whatever, is there some plan for that? And when the state gets this money to subsidize whatever plans they need and the people they need to subsidize, can they take money if it isn't used right away or something and put it into the general fund or save it for some other use in the state? Is that going to be allowed? Is there anything yet we know about this at all? I mean, how are they going to dole out this money? Nothing's been said about that, right?
Well, what I understand and what they've said is, you know, they're going to move from, right now, you know, they raise the limit, they raise your relative relationship to the poverty level by the federal government. The federal government paid for all the increase, and that was supposed to phase the states paying for part of it as this went on. I believe it can go to 75 or 80%.
Yep.
But basically, the federal government paid for the expansion of Medicaid. Right, and what they want to move to is saying, instead of saying Mr. X and his family of 3 are living at this level of poverty, they will get the federal dollars for Medicaid. Instead, it's going to be, we're going to count up and there are 4 people and they're going to get this much money and we'll set that amount of money. And that amount of money is going to be a lot less than it was. So the states are going to be forced to cover a lot less people like the good old days. I mean, that's one form. So it's going to be, or they're going to have the choice, I believe, of a fixed block grant, but it will still be based on a fixed amount of money that's far less than they have now and they're spending now. And you pointed out earlier, the state budget, it's just going to compound.
It's going to be, Nancy Wyman, when she set up this working group, said it would be about an $80 million loss for the state. 80 million.
80.
And one of the concerns is that some states, and I don't think this would happen in Connecticut, are going to do punitive things in addition. You know, they'll say you get a set amount and there's a work requirement attached to it, or there's
Drug testing
or something like that. So I don't see that kind of thing happening in Connecticut, but I do see us starving, the program being starved, and our state is in such fiscal crisis right now that we don't have the extra money to augment what the feds give us without taking money away from other programs, right? Like maybe the education cost sharing grant, or, you know, it's sort of not a good, it's a Sophie's choice for the state.
And if our state is doing better helping people in general, then people from other states are going to move here and our burdens.
Well, that kind of thing can happen too. But the cost of living is very high in Connecticut, so I don't know how many people will move here.
So we have a question right up here in front.
I thought I heard one of you say that the states were permitted to enforce the mandate.
Well, that's one thing I said in my opening remarks, that one thing that states are considering doing if Trump is not planning on enforcing the individual mandate, a state could institute its own individual mandate. You may remember
they won't be enforcing the federal mandate.
You may remember back in 2006 when Massachusetts passed their law that the ACA was based on, they instituted an individual mandate.
Okay, I thought you were talking about states enforcing, like in this situation
No,
in
it would have to be
Maryland.
enforced somehow through our state
Okay.
fiscal, through state taxes, the state, what's the office that does the taxes? Whatever.
PRS.
Yeah.
I mean, that's a bit of a theoretical thing at this point, right? Because the way Massachusetts did it was with an awful lot of buy-in from the payers in that state, right?
Right.
And Massachusetts has a very unique payer market because they
Right.
have large academic medical centers with their own insurance
Well, they
plans.
have
et cetera.
nonprofit insurers.
Right. So, I mean, part of that hinges on the ability of those health plans to agree that they will cover it. So it is. I agree. I actually think it's an idea that has some legs, but it involves, I think, a lot of coordination that hasn't started to happen yet.
We've already seen a 10% decrease in the number of people in our exchange, individuals in the exchange.
Just sheer-
Because of people just saying, well, I don't need to buy insurance, so we're not gonna do it. So it's gone down below 100,000 now. So, we're spending a huge amount of money to operate an exchange in Connecticut that serves less than 100,000 individuals. But let's just remember, our exchange also is the place where you go to get Medicaid too. So they enroll Medicaid people. It's no wrong door. You need insurance, you go here, you find out whether you qualify for these Medicaid programs. It's administered through one place. They have a big contract with the State Department of Social Services to do it.
You still have a question?
Yeah, so we've talked about access. But what about, I was just wondering if you have any strategies for bending the cost curve in addition to.
Well, we got a $45 million grant in Connecticut through Obamacare to fund work done through our state innovation model for payment and delivery system reforms. There's a lot coming into the state for, I'm chair of the community health center where I live, which are federally qualified health centers are doing a lot of work on reform. You want to talk about the accountable care work?
Yeah, that's what we touched on earlier. So a lot of things built into the Affordable Care Act were around redesign of care. And some of the big things they started off with, which have been very effective both in actually better care and people being happier and saving money, is hospital admissions and readmissions, getting people home, and then putting a lot of effort into visiting nurses, home telehealth monitoring. It's been, and just a lot more attention so that when people are not doing well, they have someone to go to. That's been very effective as one of the early steps, and that came out of money. There's part of the Affordable Care Act was the Innovation Center, the Center for Medicare Innovation Center, CMMI, and I forgot the exact funding. It was many, many billions of dollars. And the idea of that money was to create programs and try them out on a smaller scale. And they were around things like this. And one of the ones some of you may have heard or read about was medical home, in which clinics or private practices or big practices have to meet a whole series of requirements. Things like having after-hours availability, weekends, somebody answer the phones, staff, nurses or other staff who call the patients back to see how they're doing the next day or day after hospital. So really trying to build in a much tighter connection so that if, I don't have to ask you every time I ask, everybody's hand goes up, but who hasn't had a problem when they wanted to rather have called their doctor and said, what do I do, but instead ended up going to urgent care, the emergency department, or somewhere else. So really things designed around that, and that's where it has to be done stepwise. And the government was not stupid enough this time to try to do it all at once. They actually created many different innovation models, including the one that
So it's something that we can pick up from other countries, because obviously they're doing it more efficiently than we are, but.
Well, and largely socialized systems, that's the difference, right? So it's real easy if you're the UK and you have a national health system to say you're paying for quality, right? It's different if you have a disparate mishmash of Medicare and Medicaid combined and sprinkled with a bunch of commercial health plans that may or may not get on board with those things. But I think the general point Dr. Rich is making is the way you bend the cost curve is you tie payments and reimbursements to quality. You don't tie payments and reimbursements to volume.
Like, for instance, management of chronic illness.
Right.
The state employee health plan is a most wonderful example of how they've done plan design to encourage management of chronic illness prevention, primary care. You take away barriers to co-payments for, your diabetes medication, and you give people counseling, and you say to them, if you don't, go to your visits and do the things you need to do, you have to pay $1,000 more a year for your health plan. The compliance is really high in the state employee plan for those things that drive costs, like chronic illnesses.
There's a lot of other models. Transportation is a very big issue for people, and so some health systems have contracted with Uber and Lyft to actually pick people up to bring them to their appointments. Others have given out the medicines instead of expecting people to be able to go to a pharmacy, first of all get there and then afford it, and so they give them out at the visit. Others, home telehealth is a really big one. People with heart failure, maybe here who's dealt with it themselves or family, what happens is people start to build up fluid in their lungs. It takes time. And so one of the really simple tactics that works great is to set people up with an electronic digital scale that's hooked into the wireless unit at home. They weigh themselves every day as part of their routine. And then every day that's being checked. If the nurses notice, and the nurses watching the board notice that your weight has gone up a couple of pounds, they're immediately out there to work with you instead of waiting 4 days and you end up in the ER in the middle of the night and land up in an ICU and a ventilator. So there are some very big ticket items that are really bad for patients when they happen, but are really avoidable. But what happens typically. I know this from all my years in emergency medicine. Every night at about 4 in the morning, an elderly person will be brought in by ambulance, and you'll end up having to put them on a ventilator. And when you found out the story, they didn't want to bother their oldest daughter for 3 days, or something like that. And there are a lot of things like that. Not everything's reversible, not everything's made easier. But bringing patients into the choice making is the other huge part of this. But if you don't have options like that, how much choice can you make as a patient? Say with cancer treatment, there's a lot more attention to, and not death squads and all the other crazy stuff. Again, death panels. It's actually having nurses who are available that work, let's say with a group of cancer patients who really get to know them and know the options and work closely with the families all along, not waiting until they're near the end and suddenly saying, what about hospice? It's a very different approach.
But I would say to that, not to belabor the point, but I agree with everything you said, and those are terrific examples. It all starts with changing the spigot of money to pay for things that are focused on quality improvements as opposed to volume and fee-for-service. And the example that Dr. Rich used with Uber and Lyft, it's ultimately the insurance companies that reimburse for that medical transportation. There are now incentives in place because there's a massive amount of waste in the old model of medical transportation was essentially, companies in strip malls that had fleets of white vans. And if those fleets of white vans didn't show up on time and you missed your doctor's appointment, or the white van showed up and you were supposed to have one that had a wheelchair lift, but the wrong van showed up, so then the van had to go back and get another van. Each time that van's going back and forth, they're billing for that. Well, now insurance companies are saying, well, geez, Uber and Lyft can do that a lot more efficiently. Not only do they have GPS, et cetera, we know we will pay for that. Because if we can improve the quality experience and lower costs around something as mundane as medical transportation, we're willing to do that. We'll now try something new. We will turn on that spigot and start paying for those things where before we didn't, because there was no incentive to. Who cared if the van went 4 times? We'll just keep, the provider will just keep putting in for reimbursement, and Cigna will keep paying. Right? So any of these programs all hinge on a sea change in the way we think about what we're paying for. And I think there's a real concern, in particular with the new CMS administrator. CMS is the large federal bureaucracy that manages Medicare and Medicaid, which is where a lot of these programs begin, and then commercial carriers like Cigna tend to follow suit. It's a bit ironic that where the innovation actually begins is in large federal bureaucracies, because there's an incentive to save taxpayer money, and then the commercial plans hop on board after and see that it worked. There's a real concern that we have a new CMS administrator appointed by the Trump administration in Seema Verna, who doesn't seem to be all that jazzed about a lot of these value-based care programs, because in her mind they're not happening fast enough. And so, again, I say all of that because the only way we start to bend the cost curve, it all starts with where we're putting our bets in terms of where the money's being spent. Without that, you don't have Uber and Lyft instead of a white van, right? You just never will. So, period.
So we're going to wrap up. I would, before I thank everybody, I'm in charge of water and cookies. My wife will not let me take these cookies home. So don't be shy. There's napkins there. Take a few for your kid. Your son needs cookies. Take a few cookies and a couple of bottles of water. But thank you for coming. Thank you for our speakers. We're helping us out so much. Thank you. Have a great drive home and a great Memorial Day weekend.